So I will talk about fairness and unfairness in data sharing from study participants and patients, because this has been coming over and over in various workshops. And with COVID-19, there has been an intent to share more, while at the same time, there are several issues to be considered when we are sharing data from people who might not even know we are sharing, and who might not even know the purposes for such sharing. So I just wanted you to confirm that you can hear me well and see the slide.
Looks great. Sounds great.
Sounds great. Thank you. So let me start by saying that, as you all know, predictive models require a large amount of data. Researchers need to be able to find data and access data in order to make additional contributions. And I say additional to the primary producers of data who also come up with the first publications about those data. I have here just some examples, and obviously in the past year and a half, we've all been very into COVID-19 in the data prognosis, vaccination, and multiple things, which brought the public's awareness of the importance of data, importance to analyze the data, but not necessarily of all the issues that are behind it. So I'll just give an example. If we were to find out data about type 1 diabetes and HLA mutations or anything like that, if we wanted medical records, images, as well as genomic data and study data, that's not easy to find. So years ago, as part of the Big Data to Knowledge program, we created the DataMed data search engine, which at the time had 74 repositories, millions of data sets and data types. And I remember very well someone saying, you don't need to do this because Google will come up with a data search engine that will, fill all the needs of biomedical researchers and computer science researchers. It so happens that 5 years later, it hasn't happened yet. So I think that there's a lot of complications in order to do that, and I think it does require more specialized knowledge that than it's worth for some big company to invest on. Particularly, what we did was to have a free search box and then come up with a ranked list of data sets in order to look familiar with a web page search engine. And so this was, interesting. We published items about it. We recently also reused the code to do a COVID-19 data discovery index. But I think that there were lessons learned, just as Mark was telling about Bioportal and so on. So some of our lessons are that there are many more data sets than the ones we were able to display here. And many of those are related to healthcare systems that have clinical data warehouse on all their patients and so on. But for various reasons, we cannot post this data the same way as we post the availability of other data, as shown in here. So biomedical data representation and biomedical metadata representation, you have here the experts in it. So I won't talk about any particulars or technical aspects, but there are, in short, several representations exist. And one of them that are more related to my work is about which data are shared, who are the data recipients, what the data recipients can and cannot do with the data. So the authorization systems are related to it. And also dictates on how data can be collected, curated, stored, distributed, and destroyed. There are process challenges beyond the technical representation challenges. Detection and consequences of data mishandling. A system should be able to do that. So even an ontology of how the kinds of violations that can occur And also the data collectors' incentive to use standards. We all know that people are not used to taking as much care of with metadata as they do with the data that they use in publications. So again, in the course of the BD2K program, we published about DataMed, the search engine, about DATS, the data tag suite, to enable the discovery of the data sets. In late after the program was over, we also published how data access and user requirements could be started to be represented. So what I'm talking about is also what GDPR has stated, that it is very clear that you wouldn't need to know the name of the company or organization that is processing the data, the purposes, the categories of data, the legal basis for processing, the length of time, who else will receive the data, will it be transferred outside a particular enclave, or in this case, particular set of countries, what are the basic rights in the data protection, right to lodge a complaint, and right to withdraw the consent. So this is from GDPR, but certainly applies for the data we are talking about in biomedical research and in healthcare. So in this article in GigaScience, we did explain, it was primarily to explain that there are several legal requirements involved, as well as other forms of MOUs across institutions and sometimes between particular groups of individuals and so on. We also talked about how we should reuse as much as possible things that are in process right now. For example, the Broad Institute has the data use oversight system, in which they try to automate or semi-automate some parts of the authorization process. There is informed consent ontology, and there are many, there are many ways of representing this type of data. And now I would like to emphasize that it's not just because we like to structure everything. It's because there is a real need to control how the data get around. And I would say that because it's also very unclear to certain people what are the differences between de-identified and anonymized data and what are the risks involved. So I would touch on that just so that we're all on the same page, that there is a real need for automating authorization processes, and behind that there's a need for synergizing these ontologies, and also a need to understand what the problem is so we can control the use of the data. So I'll talk about partially consented and consented data. Partially consented, this is what I mean by saying we have electronic health records, and when you go for care, you consent for your data to be used by the institutions in ways that are approved by laws, and that it could be used for research without your explicit authorization, as long as it follows this legal principles. Consented data is when you actually know what exactly you're consenting to. You're consenting for your data to be used in this particular study that is investigating outcomes for a particular set of risk factors and so on. So it's more explicit what you're sharing and the purpose for what you're sharing and with whom you're sharing those data. So another word of caution is that if the consent does not include permission to link to electronic health records or other sources, this should not be done. Just because you can technically do it, it doesn't mean that it should do it. And this is because re-identification success from the so-called de-identified data depends on many factors, but primarily what is disclosed, to whom it is disclosed, and who the attackers are interested in identifying, and how much time and compute or money they're willing to spend. And when I say attackers, don't think about masked individuals in dark suits trying to do this, to get money out of people. That's not necessarily that. It can be breaches of privacy from family members, from co-workers, in other situations that are less, perhaps less advertised, but perhaps way more common. So just to remind you, the HIPAA de-identified data. What is a de-identified data set? It has to follow one of two determinations. Either an expert determines there is a very small risk that any recipient could be identified from the data, or safe harbor, which is the removal of 18 identifiers, such as dates, biometrics, names, and so on. And then there are another category called limited data sets that have de-identified data, but they also include dates. And the healthcare institutions are very familiar with processes around establishing data use agreements to exchange data for limited data sets or identified data sets with IRB approvals and so on. And this issue of dates being identifiers, there are workarounds such as shifting dates so that you're not disclosing the correct date, the precise date, but you're disclosing that within a particular window or interval. And then again, many people have studied why that too does not protect privacy. So I'll give you an example here just to be very simple. Imagine you have the data on this and you don't have the names, but you want to know if Lisa is pregnant or not. Obviously, if you have Lisa's biometric fingerprint, for example, and the data set has a biometric, you can uniquely link Lisa to this row, the first row, and discover that she makes 60K and she's pregnant. So again, the attack here is you're trying to find information about one particular person of interest in a data set that, in this case, is identified. Now imagine a data set that is de-identified and has values for laboratories or other things, other aspects of Lisa that you might have knowledge of. So in here, you can see that if you know that A equals 10 and B equals 20 for Lisa, you can do the same process and get the information you're looking for. So beyond that, uniqueness itself is not even necessary. If you, for example, have like two rows with the same kind of characteristic that you're looking for, the diagnosis, then you don't even need to necessarily identify which of these rows is Lisa, as long as you can get the information you're looking for. So there are several techniques to try to put noise into this data so that you cannot uniquely determine that Lisa is or is not pregnant, for example. And let me just make another detail here. Genomes are biometrics, right? So whenever you're talking about human genomes, you are necessarily talking about identified data sets, and that's where access control becomes so important. Sensor data, they're being used more and more, wearables, Fitbit and others. They are also, they are not biometrics, of course, but they are also, they contain information that can link particular individuals, so need to be taken as much care as biometrics. Identification in wearables. So you Google re-identification using images, using sounds, and you have all of that. So it is a pervasive problem. And sometimes you don't even need the biometric of the person of interest if you have the biometric of blood relatives in the case of Genome, right? So that's how the Golden State Killer was identified by a cousin participating in an ancestry type data set. So this, again, for a very good purpose in this case, but you can imagine other not so good purposes to re-identifying individuals in this so-called or de-identified data sets. So I say all of that because even getting a biometric of an individual and matching, just knowing it is in the database of, for example, a de-identified database of a condition that some may consider stigmatizing, that in itself is a breach of privacy of that individual who may have, consented just for the study of that stigmatizing condition and nothing else. And or a person who is just being taken care of at the hospital and happens to have their so-called de-identified data sets somehow leaked to the public. So, and I talk about this as electronic health records, but there are personal monitors, other database in attacks such as, does my neighbor have disease X? Just a curiosity query you might be able to identify if you have information about the person of interest beyond, just the usual. So this brings to question whether is it ethical to share, because people have not been explicitly asked and don't know who is sharing what for what purposes. Is it ethical not to share because new discoveries and acceleration of science do depend on sharing? Or could people choose? Is it practical? What if a massive number of people withdraw their data? Then would that damage research to a large extent? So these are all things that come into consideration when you're thinking about that. And for this group in particular, it's important that we have an ontology for consents, for all the authorizations, for all the tracking of who used the data for what purposes, and whether it was used properly or not. So privacy versus data sharing. Personalized medicine does depend on the big data. Getting enough data to study rare diseases is already difficult without thinking of privacy risks. But if you think about it, people with rare diseases are also way more identifiable in a disclosed database than people with more common diseases. It's difficult to quantify privacy risk and also to quantify the potential benefits because they might not be as immediate. Streamlined access control sharing is important. So can we publicly share everything? No, because that would violate a lot of the principles. Can we streamline access control? That might be possible, and that's why automating and then having, like you're discussing here, the ontologies in order to instrument that will be so important. So we should be able to quickly determine who can use the data for what purposes and provide controlled access that is not about just authenticating users. It's about authorizing the right users. And more than that, is about monitoring use and then also establish a system that can reward or penalize the correct use of data. So data governance is the hidden set of words that sometimes technologists try to avoid, but they are unavoidable. It's clear that the benefits of sharing must outweigh the risks, but as I said, it's very hard to measure both. Having data sequestered in an enclave, let's say, well, you can only compute here. It is a good step because data don't go widespread everywhere. However, it's not sufficient since you can breach privacy by computing in those environments, and there are currently no good ways of understand if privacy was breached or not in these enclaves. The more databases are linked to other data, the higher the risk of privacy violations. That is for sure. Researcher-based blanket authorization, so what's called sometimes the passport models, they can increase disparities, researchers who are authorized and those who are not. And they also do not provide comprehensive controls, because those researchers, they might have very legitimate uses for the topic or domain areas in which they are experts on. But in case they get curious about other things, there is a high possibility that they would be using those data without the intended use. So controlling how data are used is one way to mitigate the risks and access data on a need-to-know basis, and not having access when you don't need to know anymore will be an important thing to devise a complete infrastructure for it that currently is very, very limited and is based on honor code sometimes. So years ago, also on the follow-up of the BD2K program, we were talking about, how important it is to combine all these things, and access control with authentication.
Recording in progress.
Authorization, to have an activity ledger that not only could serve as a ledger for what has been done, who transacted which data sets, or who had access to certain data sets at some point, but also could, because we were talking about blockchain technologies, use the smart contract aspect of it to release or not these data sets according to code that is immutable, and it is transparent to anyone who wants to check. So blockchain is good for allowing others to know what's happening in terms of data transactions, verifying without having a centralized control. And also the risk analysis, of course, who should have what data and what are the trade-offs. So I put this here because even though authentication, we're very comfortable with it, there are very good methods, authorization is not that simple. And use log, attribution, and reproducibility, they all depend on recording everything that is happening so that you can later use and say what were good uses, what were uses that violated the agreements, and so on. Also attribution in publications and so on. So there needed synergism in all these ontologies, right? For data, for AI models, for applications, for evaluation measures that will be used, and also for limitations. If data sets, if models, if workflows can be published together with their limitations, it might be that people will say, well, given these limitations, I do not want access to this data because they won't do me any good. And that's a way to avoid having to, put in motion this whole authorization process. Formalizing consent, structuring consent, so that then you can develop the mechanisms for the authorization system is critical as well. Much has been said about blanket consent. You consent for everything, or broad consent. This is directly against the principle of giving people the right to choose what they want to share with whom and so on. And while it may work for 1% of the population, it doesn't work for all, as I will show next. Tracking of data, right? Doing the whole ecosystem that not only you allow people to find and access and use the data, reproduce results, but also you can track and see if it was used correctly. It had the attributions, the publications can be reproduced, and so on. It needs to have structure behind it. So privacy protection solutions exist, and I'll talk about this side of them. I won't talk about data-centric solutions of adding noise and encryption and so on, but I'll talk about how institutions control the data and how patients could control the data and study participants. And this is work derived from a long time ago that we started a Center for Integrating Data for Analysis, Anonymization, and Sharing. The models, we had this data-centric models, again, that I won't talk about, but I'll talk about the application of some of these models, of how institutions can control the data they're sharing. And one of those techniques to do that is you do live data at each institution. You distribute the algorithm so the data can be used in global multivariate analysis, but they never leave the site. So we have published some algorithms, distributed ones for federated learning, that can do this on what's called horizontal partitions. Hospital 1 and Hospital B have the same kind of data, but different patients, but also vertical partitions in which Hospital 1 and wearable manufacturer 1 have data from the same patients. And as long as the patient allows that linkage, those data could stay in the hospital or in the company without being shared, and you still can do multivariate analysis across this. It's much harder than the other type, but it's also possible. So years ago, we started a clinical data research network, initially only within the UC system, University of California, but later also encompassing the National VA and other institutions. And this have electronic health records of about 40 million people as of this point. And using that principle of institutions keeping control of the data and allowing computation according to what is considered ethical to do and what is considered under the institutional policy was something that we wanted to enable. We have done this because we have a common data model, we have agreements on the rule of engagement, shared ethics principles, and we know how to do the federated analysis for this electronic health records that are distributed in 14 types of institution. So recently, or last year with COVID-19, we decided to use that to answer questions about COVID-19 and to answer questions in a very transparent way. Both questions and answers would be published on the web. So the blue crosses here, they relate to every hospital in the VA system that contributed data. And then we'll have other institutions represented, including one in Germany, so under GDPR, and others in territories as well. So this website is covid19questions.org, whereas again, people could ask questions. Our institutions would decide whether the questions were answerable, and would go ahead and take the most important ones and the ones that we could answer best and publish the results online. So questions, again, of various types, we felt that we were more adequate questions were about hospitalizations. We had better control of that than ambulatory sites, and we had answered those online. For example, here in the very initial stages of the pandemic, there was concern about patients taking ACE inhibitors, whether they would fare worse than other patients, and then we could quickly say, no, in fact, they are faring better than those hypertensive individuals who are not taking medications, or even perhaps not significantly, but data showing that they might even do a little bit better than those taking ARBs and other antihypertensives. Of course, at that time, age was a major factor. This picture has changed now, and you are seeing mortality of younger individuals rising, as you can probably tell from your own institutions. We also did a multivariate analysis exactly to understand whether once patients are in the hospital, are there differences in outcomes related to race and ethnicity? And we were delighted to see that no, the differences were still primarily based on age once individuals were in the hospitals, and the other characteristics were, once adjusted for age, were not important. So this is important to say, because it's not simple count queries across the sites, but rather a multivariate analysis that was done without ever having to transfer the data to another site. So it works like this. Each site has a little table, for example, here, in which it is de-identified, but that table stays local. So it stays with the VA, stays with University of California, San Diego. And all we exchange during the competition is matrices such as this one that have like covariances among the variables there. So from this, it is not possible unless you have some extreme cases of one institution having just one patient, in which case we wouldn't, that institution wouldn't participate. So it's not possible to re-identify patients because only a matrix, a collective, aggregate numbers like this are exchanged. So this decentralized access to data has been done in this project, which we call Rapid Response Data Discovery, R2D2, is the model that all of us uses. All of us keeps its data on an enclave. The VA infrastructure does so, and then the Odyssey Consortium, which is various institutions that also keep their data, can use the OMOP format in order to harmonize all this. So anyone at this type of institutions or clinical data networks such as PCORNet, COVID registries, and so on, could be a node in this distributed network, and also pose a question to the rest of the network without necessarily having to define a centralized source of data that has important privacy implications, but also security, because once you breach it, you have data from everyone. Also the lack of control, because the institutions cannot say, I don't want to answer a question related to this particular aspect. On behalf of our patients, we will not be allowing that particular kind of inquiry. So the code is available publicly. So even if you don't participate in the network, but you can benchmark your hospital against those of the network, that might be a useful outcome as well. And I must say that a code discovery index is needed. There are fragments here and there, but a more concerted effort to discover such code would be important. So I talked about this data broker as the institution, and let me talk finally about, and please do let me know when my time is up. But I would like to talk about patient-defined data sharing permissions and consent management, which is something we have experimented, starting with the informed consent for clinical data used in research, our iConcur project funded by NHGRI. That followed up from the National Center for Biomedical Computing, IDASH, in which we had started several pilots related to privacy preserving algorithms. So we partner with Emory for a rare disease, Kawasaki disease study in African Americans who are more affected by this condition than others. Also partnership for epidemiological research, the study on Latinos with San Diego State University and others. The Strong Heart, we still collaborate with this group in terms of what types of sharing is acceptable for the American Indian populations participating in this Strong Heart study, which is one of the oldest cohort studies in the US, and one that a particular addresses the requirements of American Indian populations. The other one was with a federally qualified healthcare system, so a safety net health system in Arizona, about whether the consent depends on who is obtaining the consent, which is the same clinician as is providing care, or if it's an independent third party. So we, with this project, we started a line of research that is, how can we combine the preferences of groups or of individuals and make it so that we can automate these processes a little bit better. So with the process that I showed you before, the healthcare institutions are the trusted broker, and they permit the use of data or not, depending on who the user is and what they're asking. So shifting this towards a patient-centered model in which the patient could decide is something that we wanted to experiment with in terms of being practical and in terms of would that change dramatically which data are shared. And so that required a consent management system and also a lookup system in which the patient could see, well, yeah, maybe I want to be a little bit more relaxed about my permissions, or no, maybe I want to over time be more restrictive. So this prototype made many years ago was about who can access the clinical data I share, my age, my ethnicity, gender, race, and various other aspects. And this was broken down at the time, but UCSD and VA hospital, non-profit organizations or for-profit organizations. And interestingly, UCSD allowed us to do this not as a hypothetical, but we could honor those data sharing to the extent we could control for the years in which this study was happening. We used data elements in here that were published in the literature as potentially being sensitive. And again, we might have missed certain conditions or categories of conditions, but there were already a lot, and also tissue and blood sample, we wanted to know about that. In California, also because we are allowed for stem cell research by the state, that was another thing we were interested in. So this iConcur system essentially operated on the clinical data warehouse that is derived from electronic health records at our institution. And then we developed the software that goes about consent management and the entering the study conditions. So this was one of our first results with the small group. But the lesson here is the two extremes, right? This blue part on the right-hand side, about 50% are fine to share data the way UCSD has been doing. You know, therefore the answer is, yeah, you can share everything. You can share my age with anyone that you want to share. So that's reassuring. So that's 50% of people, we're doing exactly what they're saying. On the other extreme, for about 10%, depending on the item, right? We might not be doing the right thing because they don't want to share. They don't want to share this particular item. You know, it's rare the cases where people don't want to share absolutely anything. But as you can see here, some have particular desires not to share past pregnancy or to share billing information and so on. And then the other two in the middle is exactly, I think, what this project would also address, in which the purple ones say just share with UCSD, you know, don't share with anyone else, but UCSD can share. And then the other one is like nonprofit institutions. It's okay to share with those as well. So it depends on how you see it. The cup is half full or half empty in terms of matching what we're doing with what the individuals want to do. The post-selection showed that the people are more comfortable. Some people, 35, are more comfortable now to share more data once they know who's using for research, for example. The majority feel more comfortable. And then interestingly, most are sharing equally for healthcare or for research. It's about the same. A few are more willing for research than for healthcare, which again may be an artifact of how the healthcare system in the US is organized. And interestingly, they wanted to receive an update every time someone uses their data. We didn't anticipate that, but also that might be because they don't know how frequent that could be, and depending on the institution, it can be very frequent. So we followed that up with more patients, a larger sample size, but the results are very similar. You can see on the right-hand side here, same kind of coding, and then the items that people don't want to share. And I want to bring to your attention insurance status. This is right here at 9.2% of people not wanting to share that. And the reason I say that is because when institutions mandate common data elements or items that every particular study participant needs to share if they're taking part on a particular study, we might be missing, 9.2% of people who do not want to share that particular item. So this all or nothing requirements to share, I think, need to be revisited because that there is evidence that some people don't want to share what might not be as important to certain types of research than others. And I'm not talking about studies involving social determinants, but let's say it's in research involving a particular laboratory technique and so on. You wouldn't want to miss a participant because they're obligated to share certain items that they're not comfortable with. So we also thought, as expected, if you put opt-out forms, you get more people to participate than when you put opt-in forms. This was important because according to GDPR, opt-out is not allowed. So we wanted to understand that as well. So data sharing for common diseases, rare diseases, or for emergency. There's no question that Agile Controlled Data Access is needed, and there are many ways of doing this. Partially consented data, even if de-identified, pose significant ethical challenges. Consented data require data access to follow the process explained in the consent form. There is no way around that, and that should be respected. So in conclusion, protecting the privacy of the individuals is critical. Helping researchers find and access data is critical. And transparency in data use is critical. So we have, things that might not necessarily be in alignment right now, but they can be if we engineer this ecosystem correctly. The need for consent will not damage AI research. In fact, it will facilitate it. The current model of institutions deciding may be protecting too much or protecting too little, depending on your perspective. And I would say that we should promote AI fairness, the acronym, as well as this AI fairness of the choice of individuals, because in the end, that's the people we're serving with all the discoveries. So to close, I would say asking people is still a good idea. Might not be a very original one, but it's a good idea. And then also just to acknowledge the investments that in privacy and data sharing that NIH and other agencies have done, and to thank those who've trusted us in doing this, as well as the large team that we have at UCSD and various other institutions that allowed us to experiment with all of that. So with that, I want to conclude and thanks Mark and thanks Stefan for the invitation as well. Thank you.
Thanks for great talk, Lucila. As always, if people have questions, please put them in the chat. We have a few minutes left, but please put your questions in the chat. We'll try to convey those. Let me ask, you talked earlier in your talk about BioCaddy and the idea of data set search, and you mentioned a lot of the value of standardizing EHR data. You mentioned OMOP as being essential for all of us, and Odyssey and a variety of other projects. What ontology would you want to design that would allow a tool like BioCaddy to find the right EHR data out there in that vast universe of available data sets? What ontologies do we not have that we need that would facilitate the kind of data search that you mentioned?
I would prefer not to come up with a new one, but rather have a means to connect the existing ones, perfect the existing ones, so that we build upon work that, many years of work of different communities developed these ontologies. What I believe there is a disconnect in terms of, even knowing, so you need an ontology discovery index as well, right? And then knowing how to connect them in order to build these products. And I do not believe in doing this in a vacuum. I think there needs to be a project or a purpose. And from that one, you end up discovering where the deficiencies are and where things need to be improved. I think within our COVID-19 questions and answers, that's what we've figured. The question must be easy, and it must be easy to answer in one system. But once you try to do it all of the systems, if you get very different answers, it's because something is represented wrong and is not aligned. And without having a real question to go about and discover these things, we're all very comfortable with our representations locally.
Okay. Got a couple questions for you. Charlotte asked, thank you for an interesting talk. For AI models, having an insight of the data is very important, especially for debugging or understanding the choice of the models. Do you think it is compatible with the distributed system or the access to only partial data?
Yeah, I think I agree completely. Understanding your local data is the way you see, you can't participate in this federated analysis the way the data are right now, and it should be debugged at the level of the data. For models, I think it's the same, right? I think if you get the data out there without a good understanding of it, you might be lucky and your model might work, or you might be unlucky and it might not work, or even worse, you think it works and then you publish about it and so on, but in fact you come up with the wrong answer. So I think secondary use of data is a whole topic in itself, but what I like about federated analysis, you keep the people in the loop, the local knowledge of the data in the loop, and then you try to do that. So to answer, is it compatible with the distributed system or access to only partial data? I think, yeah, we will just get halfway, and if we get halfway, it's great, right? To be able to apply certain models and other data. But I think at the current situation, you cannot simply use someone else's data in, at least when it comes to electronic health records, and gets to some conclusions with it. I think there's much more work involved.
Thanks. I wish we had more time. We're really out of time now. That was a great talk. You covered a lot of ground. I really appreciate the opportunity that you had a chance to speak for us.